So we were discussing the steps of management of asthma. Now I was telling you the difference between the fourth step and the fifth step. Till fourth step, we have added 4 medication, and in fifth step, the medication are same. There's only one change is that in fourth step, we were using a fixed dose of LABA and low dose of inhaled corticosteroid in separate inhalers, and they were for maintenance therapy. While in fifth step, we'll combine this LABA and low dose ICS in a single inhaler, and we'll use it as a maintenance and a reliever therapy. So reliever therapy means whenever the patient will get symptoms of dyspnea or bronchoconstriction or cough, we will use this inhaler that contains LABA and ICS whenever it is required and not in a fixed dose. Everyone, or there is still confusion?
No, it's fine. It's clear now.
So in fifth step, the combined inhaler that we were using, it contained a low dose of inhaled corticosteroids. Remember it. Low dose inhaled corticosteroids. So we, in the fifth step, we shift the patient to a MART therapy, maintenance and reliever therapy, in the form of a single inhaler. Now, in the step 6, if the patient is still getting symptoms, then we have 2 options. Either increase medium dose ICS to prescribe an inhaler that contain medium dose of inhaled corticosteroids and LABA. In fifth step, it was low dose inhaled corticosteroids, and in sixth step, it will be medium dose inhaled corticosteroid MART therapy, maintenance and reliever therapy, in the form of a single inhaler that contain a medium dose of inhaled corticosteroids and LABA. Or we can consider changing back to a fixed dose of moderate dose inhaled corticosteroid and separate LABA. Whatever is the case, either you want to prescribe them in a separate inhalers or in the form of MART therapy, the dose of inhaled corticosteroid will be increased to medium dose of inhaled corticosteroids in step 6. Now in step 7, all the drugs will remain same. We'll just increase the dose of inhaled corticosteroids to high dose. So in fifth step, till fifth step, the dose of inhaled corticosteroid was low dose inhaled corticosteroid. In the sixth step, it will be medium dose. The drugs will remain the same. We'll just increase the dose of inhaled corticosteroid to medium. And in seventh step, we'll increase the dose of inhaled corticosteroid to high. So increase inhaled corticosteroid to high dose only as a part of fixed dose regime. Remember that in the seventh step, we can only increase the dose of inhaled corticosteroids to high dose in a fixed dose regime and not as a MART therapy, not as a maintenance or reliever therapy. We need to give a fixed dose of high dose of inhaled corticosteroids. So this step is important. In step 7, we increase the ICS to high dose in a fixed dose regime and not as a MART therapy. So this is one option that we have in the 7th step. The second option that we have in the 7th step is that a trial of an additional drug, such as a long-acting muscarinic receptor antagonist or theophylline, can be tried. Or the third option that we have in the 7th step is to seek an advice from a healthcare professional who is expert in asthma. So what we can do in the seventh step of asthma management, either increase the dose of inhaled corticosteroids to high dose in a fixed dose regime, or try an additional drug. A fifth drug can be tried, such as long-acting muscarinic receptor antagonist, or a theophylline can be tried, or we can refer the patient to a healthcare professional who is expert in asthma. So this was 7 steps of management of asthma. In the first 4 steps, we'll add one drug one by one, starting from SABA, ICS, LATRA, and in 4th step, LABA. So these 4 medication will be added one by one in the stepwise fashion in the first 4 steps. In the 5th step, we'll shift the patient to a single inhaler containing ICS and LABA, low dose of ICS and LABA, and in the MARD therapy or maintenance and reliever therapy. In the 6th step, we'll increase the dose of ICS to medium dose, and either in a MARD therapy or in a fixed dose therapy. Both of them can be tried. And in the 7th step, we'll increase the dose of ICS to high dose, or we'll add an additional drug, a 5th drug, such as long-acting muscarinic receptor antagonist or theophylline, or we'll refer the patient for specialist opinion to a professional who is expert in asthma. Some points about maintenance and reliever therapy that I have already told you, that a combined ICS and LABA treatment, which is a single inhaler containing both ICS and a fast-acting LABA, which is used for daily maintenance therapy and for the relief of symptoms as required. This is called maintenance and reliever therapy. Maintenance and reliever therapy is only available for ICS and LABA combination. So that's why it can only be used if you are requiring these 2 drugs. And some examples of low dose of corticosteroids, inhaled corticosteroids, moderate dose of inhaled corticosteroids, and high dose. So 400 microgram up to 400 microgram of budesonide is a low dose of inhaled corticosteroid. Between 400 to 800 is moderate dose, and more than 800 microgram is high dose of inhaled corticosteroids. So this was all about the 7-step management of asthma. I hope it's clear to everyone. If there is any question, then you people can ask. No questions. Now, how we can assess the severity of asthma symptoms? Moderate severity and severe severity, or life-threatening features of asthma. So moderate severity is when peak expiratory flow rate is 50 to 70% of the best or predicted. Speech is normal, respiratory rate is less than 25, and pulse is less than 110 beats per minute. If respiratory rate is more than 25 and pulse is more than 110, then we'll say that it's severe asthma. You need to remember these life-threatening features of asthma. They are important for Plab 1 exam. What are the life-threatening features of asthma? Life-threatening features are if peak expiratory flow rate is less than 33% of best or predicted, oxygen saturation is less than 92%, silent chest, cyanosis, feeble respiratory effort. So feeble respiratory effort will lead to decreased oxygen saturation. So feeble respiratory effort decreases oxygen saturation below 92%, and decreased oxygen saturation will also lead to cyanosis, and it can also lead to silent chest. So you can remember these features like this in the form of a story, that a feeble respiratory effort will lead to low oxygen saturation below 92, or the person will develop cyanosis, or his chest will become silent, or a PEFR of less than 33%. They are life-threatening features of asthma. Now, this decreased oxygen or cyanosis will lead to exhaustion, confusion, or coma as well. So remember three systems: lungs, heart, and brain, that will be affected in life-threatening features of asthma, because our life depends on these three systems. So remember these three systems and how they will be affected by low oxygen, and you will remember the life-threatening features of asthma. So for brain, exhaustion, confusion, and coma, and for heart, arrhythmia such as bradycardia or any type of arrhythmia or hypertension. All of them are the life-threatening features of asthma. So whenever life-threatening features of asthma are present, the management will be different of acute exacerbation of asthma. Now, we have discussed the long-term management of asthma. Now, management of acute asthma exacerbation. Three things are used in the management of acute asthma exacerbation, and those three things are oxygen, bronchodilators, nebulized bronchodilators, and steroids. Oxygen, if saturation is less than 92%, AMS saturation of 94 to 98, nebulized bronchodilator such as salbutamol 5 mg or terbutaline 10 mg. Both of them are short-acting beta agonist or SABA. Because we are managing acute asthma exacerbation, so we need short-acting drugs for a quick response. So after oxygen, salbutamol 5 mg or terbutaline 10 mg nebulized with oxygen. And the third thing that the third medicine, the third drug that we use in the acute asthma exacerbation is either a IV steroids such as 100 mg of hydrocortisone, or oral steroids such as 40 to 50 mg of prednisolone. This is if a person present with acute asthma exacerbation. And if there are any life-threatening features of asthma are present, the life-threatening features that we have already discussed related to lung, heart, and brain, if they are present, then we will give nebulized salbutamol every 15 minutes, either nebulized salbutamol every 15 minutes or 10 mg continuously. We need to be aggressive if life-threatening features are present. So along with SABA, we will add SAMA, that is short-acting muscarinic antagonist, that is ipratropium 0.5 mg. So if life-threatening features are present, then we'll use two bronchodilators. One is SABA and other is SAMA, which will be given every 15 minutes. And if the patient does not improve with this double bronchodilators, that is salbutamol and ipratropium, then we will try magnesium sulfate. That will be given 2 gram over 20 minutes IV.
Sorry,
So
this apretropium is a long acting.
Ipratropium is also a short-acting bronchodilator. And the mechanism of action is different from salbutamol. Salbutamol is a beta agonist, and ipratropium is a muscarinic antagonist.
Okay. Thank you.
Muscarinic receptors causes bronchoconstriction. So that's why if we use a muscarinic antagonist, bronchodilation will happen. So if life-threatening features are present, then double bronchodilator along with oxygen and steroids. And if the patient does not respond to these medications, then we'll use magnesium sulfate 2 gram IV, 1.2 to 2 gram IV over 20 minutes. Magnesium sulfate will be given. And if the patient condition improve within 15 to 30 minutes, then we'll give nebulized salbutamol every 4 hours and prednisolone 50 milligram once daily for 5 to 7 days. So in short, 3 drugs are included in asthma management. Three things: oxygen, bronchodilator, and steroids. If life-threatening features are present, then bronchodilator nebulization will be used every 15 minutes, and double bronchodilator will be used if life-threatening features are present. And if the patient condition improves, then nebulization will be done every 4 hours, and steroids will be given for 5 to 7 days. And if the patient condition does not improve, then we will nebulize every 15 minutes. So this was acute management of acute exacerbation in adults. There's a side effect of inhaled corticosteroids if the person is non-asthmatic and he develops a white patch or white marks in the oral cavity that can easily be rubbed out, then you will think of oral candidiasis. So oral candidiasis can develop in person with a history of immunosuppression or smoking, or if a person is using oral or inhaled corticosteroids. So remember that because we prescribe inhaled corticosteroids to the patient with asthma, so they can develop oral candidiasis. That is, they will have white patches that can be rubbed out easily. How to treat oral thrush or oral candidiasis? If the person is smoking, we'll ask him to stop smoking and we'll advise him a good inhaler technique and a spacer device and rinse mouth with water after use. So these are the general measure to prevent oral candidiasis. And if the person develops oral candidiasis, then antifungal drugs such as fluconazole 50 milligram once daily for 7 days will be given. So general measure to prevent oral candidiasis, they include good inhaler technique, spacer device, rinse mouth with water after using inhaler, and if the person develops oral candidiasis, then antifungal drugs such as oral fluconazole can be given for 7 days once daily. Now some points how to clean the spacer used for inhalers. Spacer can be cleaned monthly and not weekly. It can be soaked in a detergent or soapy warm water for 15 minutes. Then it is allowed to dry. No wiping with cloths or in the sun. And we should replace the spacer every 12 months. Long-term management of asthma. In the first 4 steps, all the 4 drugs will be added one by one. In the 5th step, MART will be introduced with low dose MART. In 6th step, medium dose or moderate dose ICS MART. And in 7th step, high dose of steroids in a fixed dose regime or trial of a new drug can also be given in a seventh step, that is theophylline or muscarinic antagonist, long acting. Now, sometimes a person with asthma who is well controlled on SABA and ICS or LABA, they develop symptoms of asthma or they get asthmatic attacks after exercise. So, exercise induced asthma is a sign of poorly controlled asthma. Remember that if a person is getting asthma attack after exercise, then it is a sign of poorly controlled asthma. And the drugs that can be tried for exercise induced asthma are same SABA, ICS, and LATRA. Remember that a person who is well controlled on SABA and inhaled corticosteroids or ICS, but he gets asthmatic symptoms when he exercise. So you can add either a LATRA, LABA, or sodium chromoglycate. Sodium chromoglycate is a drug that is only used in exercise-induced asthma. So this is a new drug that can be tried in a person with exercise-reduced asthma. So along with SABA and ICS, our preferred or drug of choice or first line drug is LATRA or montelukast. Second line is LABA, and then third line is sodium chromoglycate for exercise-induced asthma. Life-threatening features of asthma, we have already discussed them. Acute asthma exacerbation in adults. Three things will be used: oxygen, salbutamol, nebulized salbutamol, and corticosteroids. Either 100 mg IV hydrocortisone or 40 to 50 mg oral prednisolone. That will be continued for 5 to 7 days. And if severe or life-threatening feature present and the person is not improving with these measures, then we'll add a second bronchodilator and we'll repeat the nebulization every 15 minutes. Still no improvement, then we'll give a single dose of magnesium sulfate from 1.2 to 2 gram IV over 20 minutes. And if the patient is improving, then I will give nebulized salbutamol every 4 hours and prednisolone will be continued for 5 days. Now remember that for the management of acute asthma exacerbation in adults, we used double bronchodilator only when there was life-threatening feature present. Otherwise, we were okay with a single bronchodilator, that was salbutamol. Now, the management of acute exacerbation of asthma in pediatrics a little different from adults. In children, the management is almost same. That is oxygen, bronchodilator, and steroids. But in children, we need more aggressive management. That's why we'll add a double bronchodilators such as salbutamol and ipratropium bromide, nebulized salbutamol and ipratropium bromide in the starting. We'll not look for life-threatening features in pediatric age population. For the management, we'll use double bronchodilator from the beginning. So oxygen, double bronchodilator, and steroids. Very simple. The drugs are all the same. We just need to be more aggressive in the case of pediatric age population. And if with these measures the patient does not improve, then we can try IV salbutamol, IV aminophylline, and IV magnesium sulfate. So for adults, we had only one IV magnesium sulfate. For children, IV salbutamol, IV aminophylline, any of them can be tried. If the person, if the patient or if the child does not improve with nebulized bronchodilator, oxygen, and steroids. So this was all about management, long-term management and management of acute asthma exacerbation. I hope it's clear to everyone. So we discussed that we can differentiate between COPD and asthma on bronchodilator reversibility testing, and that is an improvement in the FEV1 to FEC ratio indicate the diagnosis of asthma. Remember that a significant improvement is you'll make a diagnosis of asthma. Sometimes after bronchodilator reversibility, there's a mild improvement in the FEV1 over FVC ratio. But if there's mild improvement, you will still call it as COPD. Because for asthma, an improvement of 12% or an increase in the volume of 200 ml or more than 200 ml is required. Like given in this example, that a 32-year-old woman who is a smoker complains of a history of wheezes and shortness of breath. She has history of eczema. Spirometry was done and showed an FEV1 or FVC of less than 0.7. So on spirometry, there is obstructive pattern. There's a history of eczema. So autopsy history and obstructive pattern of spirometry. However, there was a significant improvement of this ratio after receiving a bronchodilator. So all the points are pointing towards a diagnosis of asthma. Point number one is a history of eczema. Second is obstructive pattern on spirometry. And third one is significant improvement after receiving a bronchodilator. So the diagnosis here is asthma. Sometimes in the question, it will be mentioned that FEV1 or FVC shows a minimal improvement after receiving bronchodilator. Remember that minimal improvement can still happen in COPD. So if in the question they mention that there is minimal improvement after receiving bronchodilator, then it will be COPD. Because sometimes there is minimal improvement after receiving a bronchodilator in COPD, but the FEV1 over FVC ratio will still remain below 0.7. So if this is the case, then don't get distracted or don't get tricked by this minimal improvement after bronchodilators and select your answer as COPD. Because in asthma, there will be significant improvement, an improvement of 12% or more, or an improvement of FEV1 of 200 ml or more.
So if there is a very slight improvement, which is above 0.7, so that we will not take it as asthma, we will consider it as COPD. So there should be a significant improvement to make it as asthma.
Yes, there's obstructive pattern and the value is less than 0.7. But after giving bronchodilator, the value become more than 0.7. Then it will not be minimal improvement. If the value become more than 0.7, then it means the obstructive pattern is reversed. So it will be asthma. But if there's minimal improvement, the value will still be below 0.7, like
Right.
0.65 or 0.67 or even 0.68 or 9. It's still below
Right.
0.7, so it will be COPD.
Right. And if it is 0.8, that means that it will be asthma.
Yes. If it
Okay.
becomes 0.8 after bronchodilator, then it is asthma. Before bronchodilator, it will be less than 0.7, and it become more than 0.7, then it means the obstruction has been reversed after using a bronchodilator, and it is asthma.
Okay. That's fine. Thank you.
So sometimes you will get a patient who is having occupational asthma. Their asthma will be related to their occupation. So the hint towards occupational asthma is that uh, either the person will complain that or show concern that chemicals at work are worsening their asthma, or you may notice in the history that symptoms seem better at weekends. So if the patient asthmatic symptoms gets better at weekends, or he is concerned about chemicals at work, which is worsening his symptoms, then you will suspect occupational asthma. Some of the chemicals that can cause occupational asthma, they are isocyanate, the most commonly used, and fluor as well. It can cause occupational asthma. And so what will we do in this case? We'll do serial measurement of peak expiratory flow. Peak expiratory flow or is a small device that can be used at home, and the person can record his peak expiratory flow rates in a diary. So you will advise serial measurements of peak expiratory flow at work and away from work. So he will measure his peak expiratory flow at work and away from work, and then you will compare the two values, and then depending upon the results, a referral should be made to a respiratory specialist with suspected occupational asthma. We have already discussed exercise-induced asthma, that exercise-induced asthma is a sign of poorly controlled asthma. The drugs that can be tried, they include the first drug of choice is after ICS and SABA, LATRA or LABA or sodium chromoglycate, or even theophylline can also be tried. Sometimes they will ask you a question in the exam that a person with suspected asthma, but his spirometry is normal. We were not able to make a diagnosis on spirometry, or how to monitor the progress of asthma, or how to monitor the response of treatment. In all these cases in which suspected asthma and spirometry is normal, and you want to monitor the treatment response, uh, the test that is done is peak flow diary. Peak expiratory flow diary. Peak expiratory flow is a small device that can be used at home, and the person can record his peak expiratory values in the diary. So this is used when we are not able to diagnose asthma on spirometry, or we want to monitor the progress of the disease or response of the treatment. So remember these 2 points when you will use peak expiratory flow. That is a normal spirometry in a person with the suspected asthma, and for disease monitoring or treatment monitoring, peak expiratory flow metry or peak expiratory flow diary, it can be used. So The diagnosis of asthma is mostly clinically. Test spirometry can be done. Sometimes, if spirometry is normal, but the patient has atopy and family history of asthma and clinically asthmatic, then the investigation that we'll do is peak flow diary. Peak flow diary can also be used to monitor the treatment response. So remember these two conditions in which we use peak flow diary. One is for treatment response and the other is normal spirometry in a person with asthmatic features. Drugs that aggravate asthma, they include BAN, beta blockers, aspirin, and NSAIDs. So this was all about asthma. Now our next topic is chronic obstructive pulmonary disease.